Three, two, one. Hello, good evening, and welcome to all. This is Ankana, the assigned moderator from IJCP Group. I wholeheartedly welcome all the delegates across the country. We are fortunate enough to get supported by the doctors. Thank you, all the doctors, for taking out time to join us today. Now, I am taking this opportunity to welcome today's Master Doctor, none other than the keynote speaker, Dr. Gursaran Sidhu Ma'am. Ma'am is MBBS, MD, FIACM, FICP, FACCP. She is the physician gold medalist, HOD of internal medicine at Sidhu Hospital, Ludhiana. Now, with the help of ma'am and her wonderful insights, we'll be taking a close look on today's topic. Tumor markers play a crucial role in the diagnosis, prognosis, and monitoring of cancer. Join us for an in depth webinar on tumor markers in clinical practice, where we will explore the use of tumor markers in various clinical settings, including their application in diagnosis, treatment, planning, and disease monitoring. Without any further delay, ma'am, I'd like to hand over the session to you. Kindly proceed with your topic. Ma'am, you can present your PPT.
Right. Thank you, Ankana, for the very kind introduction. And
Can you see the present option beside settings? Ma'am, you're on mute.
can you keep guiding us? We are pressing the present button first.
Yeah, present. Then go to slides.
We go to slides.
Yeah, then you can
In my computer,
just open.
your computer. We currently support Google PowerPoint and PDF. Upload करनी है file. Do we need to upload the file?
Yes, yes.
Oh, show. Show. It is written you are on the show. Everyone can see and hear you. नहीं ये नहीं है फिर upload तो कितने से
Ma'am, just go to the present option once again.
We go to the present option once again.
Now share
Present
your screen.
present option. Now share screen.
Your entire screen.
It is written share screen.
Yeah,
Okay,
click on that.
share screen. Yes. It shows
Yeah,
MedTalks webinar.
entire screen.
Slides open नहीं करिए करिए कितने तो दोबारा चेक करिए ओपन है करिए से तो yeah, can you see my slides?
Not yet, ma'am. Have you clicked on that entire screen option?
Entire screen option. उत्ते click करता आज करता हूँ उत्ते अच्छा we have done that.
Okay. Uh, but it's not opening yet. Now you can just go to that slides where you have saved.
Slides अपने नीचे slide bar open. Yeah, we going to the slides.
Yeah, click
We
on
are
that.
on
But I cannot see your screen yet.
वापस जाओ उसे only okay entire screen into share screen share screen entire screen ਇੱਥੇ करके देखो when we are pressing on the entire screen okay 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 you can
Now
see
see
the
your.
slides.
Yes, yes, yes. I'm just adding.
Oh,
Yeah, please make it a full screen. Yes, perfect. You can proceed, ma'am.
Okay, okay, fine. Thank you, Ankan, for the very kind introduction. The topic which I'm going to talk today is a very, very pertinent topic, which we, as a clinician, day in and day night, we need to, diagnose cancers on the rise, and we need to have a suspicion, a clinical suspicion. So once we have a clinical suspicion, then we really need to go ahead with that and see what we are dealing with. So, the contents of my talk today will be what is a tumor marker and what are the characteristics and what is the application in the clinical medicine and the clinical oncology, and what are the types and what are the methodologies which are used for detection of tumor markers and their levels, and how frequently we should be estimating the tumor markers and the factors which affect the measurement of the tumor markers. So, whenever we suspect a malignancy, we confirm it by the histopathologically. And also, we measure the baseline tumor markers and then we intervene. If surgery, radiotherapy, chemotherapy is required, we go ahead with that. And then we need to do the prognosis and the tumor staging. And if the tumor markers are still rising, and we need to measure them more frequently and then decide whether we need to intervene more. And if the tumor markers estimation, the measurements is decreasing, that means that monitor markers at increasingly time interval, so it shows that the cancer is kind of in a recession. So, what are the tumor markers? These are defined as the biochemical substance. This biochemical substance, it can be a hormone, it can be an enzyme, or it can be a protein. And from where does it come? It comes from the cancer cells or from the host in response to the cancerous substance. So, what do we do about it? That we use them to monitor or identify the presence of the malignant growth. And they are different from substances which are produced by the normal cells in the quantity and the quality. Sometimes they are produced by the normal cells, but then that is where we differentiate it. How much is the quantity produced and what is the quality which is produced? So they are seen, they are measured in the blood, in the body cavity fluids, from the cell membrane, from the cell cytoplasm, and DNA. So any good tumor marker should have, good properties. So what should be the properties of a good tumor marker? That it should be present in or produced by the tumor itself, and a tumor marker should not be present in the healthy tissues, otherwise how will we differentiate? So it should be very minimum levels in the healthy subjects or in a benign condition. The level should be low so that if the level is high, then it's kinds of a raises an alarm in us so that we can do further investigations. And it should be very specific for a tissue, that it should have different immunological properties when it is synthesized in other tissues. Only then it will guide us towards the kind of malignant or the cancer which we are looking for. So plasma level of tumor marker, it should be in the proportion to both the size of a tumor and activity of the tumor. We expect that if the tumor, the size is bigger or it is more active, then the quantity of the plasma levels, they should be more high in the blood. And half life of a tumor marker should not be very long. So this why we don't want it very long, because once we are treating the patient and the patient is going into recession, the tumor marker should be able to show us the real lifetime measurements. So a tumor marker should be present in plasma at a very detectable level, even though tumor size is very small. We should be able to detect it even at the smallest level. And it is useful both for prediction of the presence and recurrence of the tumor. So, classification of the tumor markers with respect to the type of molecule. What is the molecule here? So, it could be, as I said, it could be an enzyme, a hormones, or it could be a receptor. So, enzymes or isoenzymes are the ALP, alkaline phosphatase level, and PAP. And hormones are like calcitonin. And oncofetal antigens are like alpha fetoprotein and CEA levels, or the carbohydrate epitopes, which are recognized by the monoclonal antibodies. They are like CA 15-3, CA 19-3, or CA 125. And the receptors are like we test for in CA breast, like are these receptor responsive, estrogen responsive, or progesterone responsive? Or if there are genetic changes, there is mutation in some oncogenes and tumor suppressor genes. Some mutations in CA breast, BRCA1 and 2 have been linked to the hereditary breast and ovarian cancers. So, what are the potential users? How uses? How can we use them? We can most importantly use them to screen the cancer in the general population, and then stage that cancer, and then estimate the tumor volume, and as a prognostic indicator for the disease progression. Also, when the patient is on treatment, we can evaluate the success of the treatment and also detect the recurrence of the cancer. And whenever the patient is on any kind of a therapy, chemo, radio, we have to monitor the response to the therapy and radio immunolocalization of the tumor masses. The enzymes like alkaline phosphatase, the increased alkaline phosphatase activities, they are seen in primary or secondary liver cancer. Its level may be helpful in evaluating metastatic cancer and bone or liver cancer. We know that ALP enzyme is basically made in the liver. So whenever there is a liver cancer, it shows a very high levels. And also if there is metastasis into the livers, again it will be high. Or metastasis into the bones, again it will be high. Placental ALP, regain isoenzyme, it elevates in the variety of malignancies, including ovarian, lung, GI cancers, and Hodgkin's disease. Let us see another tumor marker, PSA, the prostatic specific antigen, which we almost ask our lab people to get it done in every patient of benign hypertrophy prostate. Why we want to differentiate whether it is a BHP or it is a CA prostate. So this is a blood test which is used primarily to screen for the prostatic cancer. And this is actually specific antigen, and this is a protein which is produced both by cancerous and non-cancerous tissues present in the prostate. So men with a PSA level between 4 to 10, often called the borderline range, they have about 1 in 4 chances of having prostatic cancer. So if the PSA level is more than 10, the chances of CA prostate is over 50%. Then what will be the symptoms the patient will tell you? The symptoms could be similar to of a BHP, or otherwise the patient could also have symptoms of hematuria, bone pains, losing weight, erectile dysfunction, or trouble in the urinating, and a patient needs to apply force to push the stream of urine. Then are the tumor markers of the hormones like calcitonin. So calcitonin is actually a hormone which decreases the blood calcium concentration. It is it regulates the parathyroid and calcitonin circle, but its levels are elevated, markedly elevated in medullary thyroid cancer. Its level correlate with the tumor volume as well as with the metastasis. If there is metastasis, the levels are very high, and tumor volume also the levels are high. This is also useful for monitoring treatment and detecting the recurrence of the medullary thyroid carcinoma. However, Calcitonin levels, they are also high in some patients with CA lung, CA breast, kidneys, CA into the liver, and non-malignant conditions like pulmonary diseases, pancreatitis, hyperparathyroidism, myeloproliferative disorders, and pregnancy. So this is very, very important that even the normal patients who are suffering from non-malignant diseases like pulmonary diseases, pancreatitis, hyperparathyroidism, myeloproliferative disorders, and pregnancy, there also the calcitonin levels will be high. Now coming to HCG, human chorionic gonadotropin, this is actually a glycoprotein which appears in pregnancy. And to continue pregnancy, it's very important that the regular levels of HCG keeps rising. So if in a non-pregnant patient, if the HCG levels are high, so this is a very useful marker for tumors of the placenta and some tumors of the testes as well. High levels of HCG, they are seen in the primary testicular insufficiency also. And higher levels in CSF, if found, it indicates metastasis in the brain as HCG does not cross the blood-brain barrier. The it does not cross, and if the levels are high, that means it is the metastatic lesion inside the brains which is producing higher HCG levels, which you are able to detect in the CSF. Then are the oncofetal antigens. They are the alpha fetoprotein and carcinoembryonic antigen called CEA. Now, alpha fetoprotein, this is a marker for hepatocellular and germ cell carcinoma. It is also increased in pregnancy and chronic liver disease. And alpha fetoprotein is useful for the screening of liver cancer, and AFP levels which are greater than 400 nanograms per ml, they are indicative of cancer, except if the patient is pregnant. Then if the patient is pregnant, then it is it doesn't make any sense. It determines prognosis and monitor therapy for the liver cancer. And this is also a prognostic indicator of survival. If the levels are less than 10 nanograms per ml in a normal patient, it indicates a longer survival of healthy adults. And elevated alpha fetoproteins, it is associated with a shorter survival time of the patient. And alpha fetoprotein and HCG in combination, they are used to classify and stage the germ cell tumors. One or both markers are increased in those tumors. The CEA, carcinoembryonic antigen, it is a cell surface protein and a well-defined tumor marker. CEA is a marker for colorectal, gastrointestinal, lung, and breast carcinoma. CEA levels are also elevated in smokers and some patients having benign conditions such as cirrhosis, rectal polyps, ulcerative colitis, and benign breast disease. And CA testing should not be used for the screening. Some tumors do not produce CEA, so it is useful for staging and monitoring of the therapy, but not for screening. So the other tumor markers are carbohydrate markers. These markers, these are either the antigens on the tumor cell surface or they are secreted by the tumor cells. They are high molecular weight. They are high molecular weight mucins or blood group antigens, and monoclonal antibodies, they have been developed against these antigens. Most reliable markers in this group are CA15-3, CA125, and CA19-9. CA15-3, this is a marker for CA breast. And elevated CA15-3 levels, they are also found in patients with pancreatic, lung, ovarian, colorectal, and liver cancers. And also this can be seen in some benign conditions of breast and liver diseases. So it is not a useful for diagnosis or for screening, but it is most useful for monitoring the therapy of CA breast. Now coming to CA 125, which we all remember that it's a very important marker for ovarian and endometrial carcinomas. But it is not very specific because it may be elevated in pancreatitis, in any lung diseases, in breast, or in colorectal GI cancer. So it is, though it is very important marker for CA ovaries or endometrial carcinoma, but still it can be high in other pancreatic, lung, breast, colorectal GI cancers. If the preoperative level of CA125 is less than 65 Ku per liter, it will be associated with a greater 5-year survival rate than a lady who has a level greater than 65 Ku per liter. So it's useful to detect the recurrence of cancer also. Supposing patient has been treated, the levels have gone CA125 very low, and on the follow-up, you again find the levels have gone way higher than 65. Look for the recurrence of the disease. So very high CA125, they can also be seen in benign conditions such as cirrhosis, hepatitis, endometriosis, pericarditis, pancreatitis, and early pregnancy. So it is also useful in differentiating benign from malignant disease in patients with ovarian masses. Now coming to CA 19-9, and this is a very important marker for both colorectal and pancreatic carcinoma. However, the elevated levels they are seen in patients with hepatobiliary, gastric, hepatocellular, CA breast, and also in benign conditions such as pancreatitis or benign GI diseases. But CA19-9 levels correlates with the pancreatic cancer staging, and it is very useful in monitoring pancreatic and colorectal cancer. The elevated levels of CA19-9 it can indicate recurrence before detected by the radiography or clinical findings in pancreatic and colorectal cancer. Now coming to the protein markers, the most reliable markers in this group are beta 2 microglobulin, ferritin, thyroglobulin, and immunoglobulin. The beta 2 microglobulin, this is a marker for multiple myeloma and also for Hodgkin's lymphoma. And it also increases in chronic inflammation and viral hepatitis. Ferritin is a marker for Hodgkin's lymphoma, leukemia, liver, lung, and breast cancer. Thyroglobulin is a very useful marker for detection of differentiated thyroid carcinoma. The immunoglobulins, the monoclonal immunoglobulin, they have been used as marker for multiple myeloma for more than 100 years. So monoclonal paraproteins, they appear as sharp bands in the globulin area of the serum protein electrophoresis. So Bence-Jones protein is a free monoclonal immunoglobulin light chain in the urine, and it is also a reliable marker for multiple myeloma. Now coming to the receptor markers, these are very very important markers because they kind of revolutionize the treatment of the CA breast and the survival of CA breast cancer patients. The more the survival these days we are looking of breast cancer, because we say like it's well or not cure, but it's almost like near to cure, is because of the receptors which are responsive to the treatment. So estrogen and progesterone response, the receptors, they are used in the breast cancer as indicators for hormonal therapy. So patients with positive estrogen and progesterone receptors, they tend to respond to hormonal treatment. Those with negative receptors, they will be treated by other therapies. So hormone receptors, they also serve as a prognostic factors in CA breast. Patients with positive receptor levels, they tend to survive longer. The curve2, HER2 new, it is a receptor for epidermal growth factor, but it doesn't contain EGF binding domain. It serves as a co-receptor. In the case of increased expression of curve B2 leads to co-autoactivation and increased signal transduction. The genetic changing, there are four classes of genes which are implicated in the development of cancer. The proto-oncogenes, which are responsible for normal cell and differentiation, tumor suppressor genes, which alteration on these genes may lead to tumor development. Apoptosis related genes are responsible for regulation of apoptosis. DNA repair genes, which are involved in recognition and repair of damaged DNA. So, what is most important is the screening for cervical cancer, and this includes the pap smear or the HPV test. It's very important and necessary preventive procedure for women starting at the age of 21, though not required after the age of 60, and not required in patients who's undergone hysterectomy. A pap test is used to detect cellular abnormalities in the cervix that may lead to cervical cancer, and an HPV test looks for the virus that may cause these abnormalities. Cervical cancer screening has been found to reduce mortality from cervical cancer by two-thirds. Earlier, the detection, it's like hit it fast and hit it quickly. So now, whenever we are thinking, please remember this picture. You're thinking of a lung cancer, send for CA125 and CEA. You are thinking of CA breast, send for CA125, CEA, and HER2. You're thinking of a stomach cancer, send for CEA. You have seen on radiologically something in the liver, send for alpha fetoproteins. If pancreas, then send for CA125 and CEA. If colon is the suspicion, send for CEA. Ovaries, ovarian cancer, CA125 and CEA together. Prostate, PSA is must. And testicular cancer, AFP and HCG is important. So with that, thank you very much. I finish here and I'm ready to take any questions.
Thank you so much, ma'am, for this comprehensive talk. Ma'am,
Oh,
we have received few questions. With all your permission, can I put them across?
yes, please.
Okay. The first question we have received, that is, what are the most commonly used tumor markers in clinical practice and what cancers are they associated with?
I've already detailed them. Do you want me to push to the other slide? The last slide I showed. Again, I can show the slide once again. I have just, please enter the bar slide. The end slide again I can show you. Well, this picture really demonstrates, these are the cancers. This picture again, I said, you suspect lung cancer, go ahead with CA125 and CEA. You're suspecting breast cancer, go ahead with CA125, CEA, and HER2. For stomach, go ahead with CEA. For liver, go for alpha fetoprotein. And for pancreas, go for CA125 and CEA. For colon cancer, CEA. For ovary, CA125 and CEA. And for prostate, PSA. And for testes, testicular cancer, alpha fetoprotein, and HCG. So these are the according, just quick reckoner.
Okay. We are moving to the next question. How should changes in tumor marker levels be interpreted in the context of patient management?
Yeah, we delineated each and every tumor marker. We said that once you've suspected, you confirm the diagnosis histopathologically, and you have sent the specific tumor marker, and you have found the tumor markers are high. You give a proper treatment to the patient, which could be, a surgical intervention, it could be radiological, it could be a chemotherapy intervention, and then follow these tumor markers according to whatever the tumor markers were high. and then repeat them sequentially. There you will definitely find, when the disease is disappearing or decreasing or going into recession, the tumor markers, the level will come down. And also, if they are recurring, you have said the patient is fine, but you must again test for a tumor marker because it is easy to test after 3 months, 6 months. And if the levels are down, you could be happy there that your disease is under remission. But if it shows a high, then suspect that there's a recurrence or there's a metastasis.
Okay, we are moving to next question. That is, how should discuss the potential of liquid biopsy and circulating tumor DNA in the future of cancer diagnosis and monitoring.
Now, please repeat once again.
Discuss the potential of liquid biopsy and circulating tumor DNA in the future of cancer diagnosis and monitoring.
Yeah, this is a very in thing, and this has a great future because biopsies, liquid biopsy is showing very good promising results. And without the biopsy we are nowhere, because these days the cancer cells, all they need to be marked immunologically as well, because that's how we say we're going to hit the target. We're going to be very specific. The therapies are going to be, they are very very target therapies these days, what we call, they are immunologically targeted. So that's how the treat. And the tumor markers help when the patient is going into recession. The medicine is helping, the tumor marker levels will go down. And also we can keep them monitoring. If the patient is in recession, we can decrease the dosages or monitor the dosages like that only. But if suddenly you find that the tumor markers are again going high, then you must suspect again that either there is a recurrence of the disease, or there is a metastasis somewhere, or there is some other primary.
Okay, we are taking the last question for today's session. What are the considerations for choosing appropriate tumor markers for a specific patient?
Absolutely. We're not going to go haywire. That's why I said, patient is a smoker. He's come to you with high grade fever for a long time. He's a smoker, and you're looking at some lesions you have suspected. There's something in the mediastinum, there's broadening on the X-ray. You order a CT scan and you find maybe it's a lymphoma, maybe it's a CA lung. So you send your specific tumor markers for the CA lung, you send for CA 125, you send for CEA, and if they are high, you are very near the diagnosis. Of course, still you will have to prove histopathologically. You just cannot say, that one tumor marker is high, this is high, because the tumor markers can also be high in a normal benign conditions as well, as I have discussed. So histopathological diagnosis is very, very important, and then use the specific tumor marker for maintaining the treatment, and looking if the patient is going into recession, and then looking for if the patient is again showing some growth of the tumor. So like PSA, you can continue marker, you can see if the PSA levels are going high, you should be suspecting CA prostate. Although in any kind of infection, even in benign condition, it would be high, but a rising titer of a tumor marker, it helps us to make the diagnosis of the malignancy.
Thank you so much, ma'am, for answering all the queries of our doctors, and thank you for your expert opinion that you have shared. I'd also like to thank all the participating doctors for your continuous participation at our platform. Thank you once again, ma'am, for your valuable time and for being with us at our platform and sharing such valuable insight with us. With all your permission, can we end the live here, ma'am?
Sure, sure. Thank you so much. I
Thank
really
you.
feel delighted getting connected with you. And I really thank you for giving me an opportunity to get connected with the big group and with the physicians all over. Thank you very much.
Thank you so much, ma'am. Thank you.
Uh,
Ma'am, you can just leave the studio.